Disclaimer, these are my views. Some of the issues that are going to be discussed are well known at Jefferson Center, so Kiara is working on them along with a lot of other really thoughtful and caring people. So I talk about these issues to shed light on what's happening, and I hope to get some help. Thank you to the Colorado Department of Human Services for providing the opportunity for public testimony regarding ways to improve mental health and behavioral health in the great state of Colorado. My name is Sari Surkis. I'm a licensed clinical social worker. I've worked in outpatient community mental health since 2010, first in Brooklyn, New York, and then in Denver, Colorado. In 2014, when I moved to Colorado, I joined Jefferson Center. My role at Jefferson Center as a clinician is to primarily serve commercial insurance and Medicare to clients to broaden the center's mission to serve everyone in the community in addition to Medicaid. I'm now a coordinator, and I help to manage a team of 40 clinical staff throughout Jefferson, Clear Creek, and Gilpin counties. Last year, my team served approximately 5,500 unique clients that have Medicare, TRICARE, and commercial insurance. I want to build upon the testimony of the executives at Jefferson Center and Front Range Health Partners, including Kiara Kunzler, Lenya Robinson, and Bob Dyer. There are many things that we are doing well to serve our community. However, improvements can be made in the areas of access and impact to care. We know that there are many people in our community with private insurance, TRICARE, and Medicare who are struggling to access services. And we need to invest in exploring opportunities that can sustain and support our ability to grow access to care in these areas. I think about insurance in everything I do. When doing an initial assessment with a client and making determinations about diagnosis and treatment, I consider insurance. If a client can benefit from weekly therapy and has a $40 copay, which is very common with Medicare, then there is a conversation with the client about what they can afford on a fixed income. And the treatment recommendations are modified to every other week or even once a month. If a client with private insurance loses their employment during the course of treatment, they scramble to navigate the health insurance system and determine if they can qualify for Medicaid. Consumers with mental health conditions often have sporadic employment, leading to multiple changes of insurance and changing costs of health care multiple times during treatment. This can result in high outstanding balances and puts an undue financial strain on the therapeutic relationship, a place where they are seeking help and support at a time when the daily stress in their lives is growing. People will regularly make compromises to reduce or discontinue treatment due to insurance and financial constraints. This negatively impacts their mental and physical health, which negatively impacts the community where they live. I can provide many examples of this. In his testimony, Bob Dyer talked about the benefit of increasing groups in outpatient mental health. Groups are high impact. They are able to increase services to many consumers with fewer providers. But insurance plans specify the provider license type required for reimbursement of service. This is true for individual therapy as well. That means I need to consider the license type of the provider to serve each of these payers. Notice I said to serve the payers, because at this point we are serving the payers before we are serving our patients. Jefferson Center recognizes the professional licenses of psychologists, clinical social workers, professional counselors, and marriage and family therapists. The agency provides continuing education, ongoing supervision, and training to support the maintenance of these license types. Dictating a specific provider license significantly narrows the options available to incoming clients. It creates unnecessary barriers to access and decreases our ability to provide broader services like groups. It creates undue administrative burden on managers and billing departments to navigate and track the multitude of exceptions to each billable claim that we are able to complete. Our agency provides a number of services and eats the cost because we got it wrong when the client came through the door, not to mention the many changes in insurance that may happen along the way during their episode of care. My 10 years of experience is in outpatient community mental health. These are my pain points as an outpatient provider, and my wish list of what I would like to see change. First, around parity.
You have about 30 seconds left.
I'm going to go over. Frequency of treatment in mental health is not the same as in medical services and must be considered for there to be true parity. A consumer might see their primary doctor 2 to 4 times a year, while they will see a mental health provider for therapy once a week or every other week, especially at the start of treatment, and will engage in therapy for about 3 months and oftentimes longer, depending on their issues and if they can afford it. Copays need to be $15 or less to make access to mental health accessible and affordable. This impacts Medicare, TRICARE, and all commercial payers. It happens every day. A consumer will attend their initial mental health appointment and learn they have a copay of $40, $50, or $60 or more. They recognize that they cannot afford to commit to the cost of treatment, and they withdraw immediately, never really being able to see if mental health services would have helped. This can lead to prolonged moderate mental health issues, feeling like the door has been closed in your face, and increase the risk of serious mental illness, suicide attempts, or hospitalization further down the road. As a consumer, I would like to make one quick statement about early childhood services. The early childhood services in Jefferson County have been excellent for my niece, who is diagnosed with severe autism. My niece qualifies for Medicaid, which covers all of her treatment services. My sister pays out of pocket for full-day preschool, which is $1,200 to $1,500 a month. If she gets a full-time salary, the prospect of losing Medicaid for my niece is scary. This is systemic poverty. Employer-based insurance is crappy compared to Medicaid, and she would be worse off if she worked full-time. Please close the gaps between Medicaid and commercial insurance for behavioral health services. Allow outpatient community mental health to serve everyone in the community, not only Medicaid. You can do this by passing legislation that allows Medicare to recognize LPC and LMFT provider licenses to provide therapy services. We have tried to pass legislation like this before and it has been defeated. I am an LCSW and I am in favor of this change. Let's introduce a bill to recognize these licenses that will become legislation. Please pass legislation to encourage commercial insurance to expand coverage for phone therapy and video therapy services. Please pass legislation to encourage Medicare, TRICARE, and commercial insurance to provide coverage for peer counseling and intensive case management for people with serious mental illness. We are currently not able to provide services for high-needs Medicare, TRICARE, or commercial insurance consumers because these services are simply not part of their coverage. People think that if they get in the door of a community mental health agency that they have access to all the services we have to offer. This is simply not true, and I wish one day that it will be. Third, I want to make a comment about housing for the homeless in Colorado. It is demoralizing to human beings to provide housing by lottery, period. It is demoralizing. I was shocked to the core of my soul to learn that there are lotteries for housing. This has to be changed. Please take a look at the New York City Department of Homeless Services. They are able to provide a daily census of how many people are coming into the shelter system each day and how many people are in the shelter system at any one time. For example, on January 15, 2020, there were 59,905 individuals in shelters across New York City. In a city of over 8.5 million people, they know exactly how many people are voluntarily in the shelter system at any given time. New York City has 3 points of entry for shelters, one for single males, one for single women, and one for families. They have an intake and are assigned a case number and a shelter location. This is their assigned shelter for 12 months. All of the permanent housing options are part of the New York City Homeless Services Network, even mental health housing. Homeless people in a shelter are put together an application for permanent housing and send it out to housing units throughout the city. People interview at a location that has available housing and an offer for housing is made if both parties agree. Please create conditions for developers to add permanent housing for the homeless that can integrate into our communities, and establish a structure for tracking and studying the homeless population in Denver metro area. In 2020, Denver's metro's population is anticipated to increase to more than 3.3 million people. It is time we start thinking like a big city and address the issues of homelessness. Thank you for listening. If you would like to follow up with me directly for more detail on any of these issues, I can be reached at saris@jcmh.org. Thank you.